Okay, recording is in progress. I guess we're going okay. Okay. Well, again, thank you very much to NABA for inviting me to speak. Uh, Low vision is certainly an important subject, and it's probably best that we first define what it is. You know, what is low vision? It's defined really as poor vision that can't be corrected just with glasses or contact lenses. If you're just having trouble reading and you have to hold something far away, that's not low vision. Uh, it's actually better defined as, with your better eye, with the best glasses you could wear, your better eye sees 20/70 or worse, you're considered to have low vision. And to put things into perspective, legal blindness is 2200 or worse. So there are plenty of people who are not legally blind who still have are considered to have low vision. Uh, and again, there is another definition of legal blindness. It's somebody with extremely restricted peripheral vision, which is another form of low vision. And again, I want to emphasize this is not that you can't see when your glasses are off. If you can see with your glasses on, you do not have low vision. Things that people will describe when they have, if they have low vision, uh, blind spots, something I like to call Swiss cheese vision. You can see something in part of your vision, but in another part of your vision, it's blocked out. You almost have to move your eye around to see what it is that's right in front of you. Night blindness, once the lights go down, you can't see much of anything. Extreme loss of peripheral vision, or if things are just very blurry or hazy so that you can't really focus upon them. When you want to think about what it is that can cause low vision, it's best to think of the anatomy of the eye. And what I like to do is I like to think of the eye as being like a camera. Uh, the light comes in through the pupil, gets focused by the lens and the cornea, and gets developed on the film. Some of us remember when cameras used to have film in the back. Well, the retina is like the film of the camera. The image comes in that you're looking at and gets focused on the retina. So different conditions, different problems with different parts of the eye can cause low vision. Probably one of the most common causes of low vision, if not the most common, is macular degeneration or atrophic macular degeneration, abbreviated. You'll often hear it abbreviated as AMD. The best way to think about what macular degeneration is go back to thinking of the eye like a camera and think about the film wearing down. If the film has been in the camera for too long, it's been sitting there for years and years because you haven't used that old film camera, well, the film isn't going to take such good pictures anymore. The film is going to be grainy. The lenses can be perfectly clear, but once the image hits the retina, it's just not going to develop properly. And this would be the result. The part of the retina that isn't working isn't seeing what's in front of you. And this is, again, what I often refer to my patients as Swiss cheese vision. You see, some things are clear, but it's like looking through a piece of Swiss cheese. This is clear here, but this is not. Diabetes can cause many different problems in many different parts of the body, and it can cause different problems with the retina. Instead of, and again, getting back to our analogy, thinking of the eye as a camera. In the case of macular degeneration, the film is just wearing down. In the case of diabetic retinopathy or diabetic retina disease, the circulation to the retina isn't working so well, so the retina itself won't work so well. So it's not so much a degeneration with age, it's more that the circulation just is not providing proper support to the retina, and it's not going to give you a good picture. So that's how diabetes would cause a problem. I spoke a little bit about tunnel vision. Glaucoma is a condition that in extreme cases causes tunnel vision. And you can almost think of it as being the opposite of macular degeneration. In macular degeneration, you have wearing down of the retina. With glaucoma, it's actually the optic nerve that has the problem. And in the way that glaucoma progresses, it takes away your peripheral vision, usually takes it away quite slowly in a way that you're not really able to, uh, in a way that you're not really able to be aware of it um, until it's pretty much too late. And I'm going to pause here for a second because we had a question about the uh, what I mentioned about diabetes. There's a question about if you're pre-diabetic, should I be concerned about diabetic retinopathy? Uh, the answer is yes, but your risk is quite a bit lower. Uh, Pre-diabetes, the problem with pre-diabetes is that it sometimes progresses into full-blown diabetes and therefore can cause retinopathy or other diabetic problems. Uh, the way you deal with diabetes in the eye is you get your eye checked every year because, and this is a good point, if you have diabetes in the early stages of diabetes, there are no symptoms. Your retina still manages to function well. Your vision seems to be good because it is good, but the circulation is slowly but surely worsening. You don't want to wait until the circulation gets so bad that the retina stops functioning. At that point, it's almost too late to do much about it. If you, on the other hand, can catch changes in the appearance of the retina before the function of the retina is impaired, you can actually intervene and do something about it. Now, certainly, if you're pre-diabetic, or pretty much all of us should keep good control of our sugars, get them checked reasonably regularly. Controlling your blood sugar is probably the single best way of preventing diabetic eye disease. The other ways of helping controlling your blood pressure, controlling your cholesterol are also very, very important, but keeping your sugar under control is going to be crucial. And it actually took years and years of research to prove what seems like it would only be common sense, that if you control your sugar, you're going to do better. But it took a lot of research to show that, but has been definitely shown that controlling your sugar will slow down the rate of any deterioration of your vision. So getting back to the question, if you are pre-diabetic, you should be getting your eyes checked yearly because yes, you are at risk for diabetic retinopathy. Getting back to glaucoma, glaucoma is a silent condition, much like diabetes in the early stages. And this is something that can be picked up before it causes a problem by regular eye exams. And if you think I'm hitting at a theme here of it's important to get regular eye exams, you are correct, because that is going to be one of the themes here. But you can also imagine that if you have peripheral vision restricted in this way, yeah, you can see what's on television, but you can't see what's around the television. And this could cause all sorts of problems for mobility. You're not going to see what you're walking past. This is another form of low vision. There are other causes of low vision. Retinopathy of prematurity, babies that are born premature, especially those that are rather sickly when they're born or require a lot of oxygen, their retinas tend not to develop very well. As a result, the vision can be quite poor in babies that are born premature. And yes, you do prescribe glasses to try to optimize the vision, but there are limits to what the retina is capable of seeing if it's been born premature. People that have had a stroke can certainly have an effect on their vision. Eye injuries is kind of self-explanatory. And there are various inherited diseases, of which retinitis pigmentosa is probably the most recognized. Various forms of inherited diseases that either in early childhood or even later on in life can affect the vision in such a way that you develop low vision. One last thing I'll mention is cataract. Now, cataract is often not considered a cause of low vision because it's correctable. You have cataract surgery, it takes care of the problem. But there are some people who are unable to have surgery, unwilling to have surgery, and as a result have low vision because of their cataract. In the case of a cataract, the problem is not with the retina, it's with the lens of the eye. The lens of the eye does not allow as much light in because it's getting cloudy. A cloudy lens is a definition of a cataract. I don't know why we don't just call it a cloudy lens, but I guess the early observers thought it looked like a cloudy lens looked like a waterfall, so they call it cloudy lens. we refer to a cloudy lens as a cataract. So if you have a cataract that's blocking light getting into the eye, you would have low vision from that. Again, it's treatable with cataract surgery, but sometimes you just can't do the surgery. So how do you diagnose low vision? Well, you see your eye doctor. You get your vision checked, usually by reading an eye chart, and you undergo a comprehensive eye exam. Very often, this is going to involve drops to numb your eyes so that we can check your eye pressure for glaucoma. Very often, it's going to involve dilating your pupils. So bring some sunglasses with you to that exam, and maybe even bring a driver if you're not sure if your dilated pupils will keep you from driving. But it's important to get an eye exam. And especially if you have diabetes, if you have a family history of macular degeneration, these are things, a family history of glaucoma. These are things that really, if you catch them early, you can hopefully prevent the disease from progressing to the point that you have low vision. But an eye exam is extremely important. When we talk about treatments, the thing to keep in mind is that treating the problems that I described earlier are really just ways of maintaining the vision that you have. And that's absolutely important. But I don't want people to go away with the impression that just because glaucoma is treatable, you can let it go for years and years without treatment and then decide to get it treated and have it go away. That's not what happens. Glaucoma, once you've lost vision from glaucoma, it doesn't come back with treatment. What you do is treat the glaucoma so that the vision loss the rate of vision loss slows down. With macular degeneration, there are treatments if you have dry macular degeneration. And you know what? Let me backtrack and talk about macular degeneration just a bit. There are two forms, dry and wet. The dry form means that the retina is deteriorating and the function is being reduced. The wet form means that in addition to that deterioration, there's bleeding behind the retina, leaky fluid behind the retina. The dry form usually causes vision loss over a long period, whereas the wet form causes vision loss over a very short period, sometimes overnight. There are treatments for the wet form. They've been in the news. They're actually not in the news anymore because it's kind of old hat. There are ways to treat the wet form of macular degeneration, but all that the treatment does is revert it back to the dry form. So it's not like you should hope that your macular degeneration is wet so that you can treat it. Really, all it does is dry it back out again, but you still have the macular degeneration. The treatment is designed at preserving vision, not at restoring the vision. So that's why getting your eyes checked on a regular basis to intervene if there's even a mild amount of loss is important, because as time goes on and your condition worsens, you're just going to have that much more trouble treating it. There's injections of medications that you can give into the vitreous fluid of the eye that treats diabetes or macular degeneration. Again, it gets the leaky blood vessels to stop leaking, but you still have the underlying problem that led to that in the first place. There are laser treatments that could be done. Again, those are really designed at sealing up leaky blood vessels. And when it comes to glaucoma, you can lower eye pressure. But again, and I don't want to sound like a broken record, but what you're doing here is you're preventing worsening of the disease. And that's important, but you're not reversing it. So you really want to be proactive in getting your eyes checked. You really want to be on top of this so that you can have an intervention before the vision gets worse. So what happens when the vision does get worse, when you do have low vision? Again, the medical treatments that I described are not going to make the vision get better, but there are ways of compensating for low vision. And Kiyosha and the other speakers have already mentioned some of these, but you basically have to learn how to maximize the vision that you have remaining. And this is a team approach. This is not one person just taking care of everything. Your visual rehabilitation team often includes the ophthalmologist that maybe made your first diagnosis of macular degeneration. It includes a low vision specialist, which is actually different. Not there are ophthalmologists and optometrists that specialize in low vision, and there are many of us who do not. Yeah, and probably the best way to ask if you're seeing a low vision specialist is to ask them, "Hey, are you a low vision specialist?" Seems like common sense, but it's a perfectly reasonable question, and certainly somebody that doesn't specialize in low vision or have a strong interest in low vision treatments isn't going to bill themselves as a low vision specialist. So that's a very reasonable question to ask your doctor. It's going to include an occupational therapist, maybe a social worker, a specialist that can help you with the technology that you've already seen some examples of. And there are many others. I couldn't list all the different people that are involved as part of the visual rehabilitation team. And it really is a team. Compensations for low vision, good lighting. That's probably the single most important thing because it's the easiest thing to accomplish. And people, a lot of my patients think that I must have stock and lamps that have goosenecks. Sometimes I even have to explain what a gooseneck is. If somebody is from the city and doesn't know what a goose is. But basically bringing the light source close to what you're looking at becomes important. An overhead light by the time the light from an overhead light gets down to your book, it's already been dispersed quite far. On the other hand, if you have a gooseneck lamp, you can bring that bulb almost on top of the book and really light things up. A good strong flashlight, you can use the flashlight that's in your phone to really magnify things. A lot of people do that in restaurants with the lighting is low and you're too vain to put on reading glasses. You break out the light from your phone. I'm not sure which is less vain, putting on reading glasses or using your phone light, but it's a way of maximizing the vision that you have. So lighting things up. Probably the single most helpful type of technology, and again, I don't sell these types of, I don't sell these types of things, but the iPad and the Kindle, electronic readers of any kind, the Nook from Barnes and Noble. I don't know of any other brand names. I don't want to favor one over the other, but basically the electronic readers, once you get used to the idea that you're not holding a book in your hand or a newspaper in your hand, you don't get the feel of turning pages. Once you get used to that, these electronic readers have been really revolutionary for a lot of my patients. They're illuminated. You could really crank up the light. Yes, it drains the battery a little faster, but if it makes a difference in reading, it's worth charging it often. You can enlarge the font to quite large letters, and you can change the background colors. You can have black on white, you can have white on black, whatever allows you to read more comfortably. There have been a lot of people that for years had been unable to read the newspaper. Once they got themselves a laptop or a tablet like this, they were again able to start reading the newspaper again. I can't speak to the content of newspapers these days, but at least it is satisfying to be able to have the option of reading a newspaper, reading a book. One nice thing about the Kindle is, at least with my Kindle, if you're not sure what a word is, you press on it and it gives you the definition. So you don't have to look up stuff in a dictionary. So that's a good thing too. And again, I don't have stock in Kindles, so I'm not trying to sell you on that, but it's been a revolutionary type of thing that's readily available to people of low vision and people who don't even quite have low vision by definition, but still find it frustrating to read. Those have been great. Getting your eye examined to optimize your vision, optimizing your vision with glasses. Very often it's the case that even with glasses you have low vision, but the vision is at least better with glasses than it is without glasses. So you want to have the best possible glasses that you can have. So you want to get your eyes checked. You should be getting your eyes checked regularly anyway to monitor the condition that's giving you low vision, to prevent developing a condition that gets low vision. having the best glasses you can have, every little bit helps. When you have low vision, every little bit helps. So that's where glasses come in. Again, I told you that low vision is defined as poor vision even with your glasses on. Well, yes, but you still need your glasses to basically get every little bit that helps. People have been able to enjoy books if they're on audio tape. They're becoming increasingly available either by streaming services, or I might even still have some cassette tapes, but there's different technologies, CDs, depending on how far advanced you are on the technology spectrum. There's some way that there's a book that could be read to you. The reading of the books has become a bit more of an art form, so that it's not just somebody droning on and on. It really is somebody that's entertaining, maybe an actor, maybe somebody that is, there's a whole profession that's gone into reading books to people, having books on tape. So it really has come a long way and has really made it possible for people to enjoy literature, and even popular books with books on tape. Large print books and ebooks, I mentioned those. Concerning glasses, is it beneficial to get the blue light filter in the lenses? As far as low vision is concerned, it probably does not make a difference. As far as the sleep disturbances, that if you're using your tablet late at night, looking at your computer screen late at night, or in the evening even, you'll probably have fewer sleep disturbances if you have the blue light filter. You can get the filter either in the lenses of the glasses, or you can get a blue light filter that covers your tablet. But what those filters do is they cut down on the higher intensity blue light. Some people also report that eye strain is reduced. So if you're going to be using your electronic device in the evening when you should be settling down and getting to sleep, the blue light filter helps that. And in some cases, it might help with eye strain. So the blue light filter is certainly a reasonable thing to consider. And I don't, as far as I know, it doesn't add, I don't know how much it adds. I don't sell glasses, so I don't know how much it adds to the cost of a lens. But it's certainly something to consider. And does the blue light harm your vision? Not as far as we know. There's been studies looking at what's called the high intensity blue light, close to the ultraviolet range in vision. There's been some thought that maybe that contributes to macular degeneration. It's starting to look like that's probably not the case, but I think the jury is still out on that. The traditional, the lesser intense blue lights almost certainly do not cause harm to your vision. There are other devices out there that help with that. Magnifying glasses, you can use either a platform lens device that you move along a page, something you whip out of your pocket to read something. Obviously not something you want to do any prolonged reading, but if you want to glance at something, you can whip that out of the pocket. Again, something mounted so that you can look through it. You can buy clocks. They have digital clocks for those of you out there that are too young to remember what a clock looked like and it had hands on it. But different devices can be made more readable and therefore easier to use. And you can get fancy. You can have a book that you put onto a scanner and have it projected onto your screen. Used to be that these were prohibitively expensive. I think the cost of these has come down. Obviously, something like this is not quite as portable as the other devices. However, for your desk at home, this is often something that could be very useful. And the important thing to know when you have low vision is that you're not really alone. And this is certainly not an exhaustive list, but there are various sources, and I've included some links here. There are various sources that you can contact to get assistance. The, the Library of Congress has the National Library Service for the print disabled. Aurora Ministries has audio Bibles. Independent Living Aids, independentliving.com. They used to drop off catalogs to my office, which people found incredibly helpful. A lot of the devices, the fancy magnifiers on platforms can be found in there. And probably the single most important resource for my patients in Saratoga has been NABA. And I'm not saying that because NABA is listening. I'm saying that because really the way I've described them to people is they're like Santa Claus, the Easter Bunny, and the Great Pumpkin all put in together. They provide so much of what people need, people can benefit from. And really, I'm so fortunate to be practicing in an area served by NABA because it takes one phone call for me to know that my patients are going to be well cared for. They're going to see the low vision specialist. They're going to see the team that really can make the difference for them. And really, it makes a difference. I almost get choked up when I talk about NABA because really they are that good. So whether you're south of Route 29 in Saratoga and you go to Albany, or you're north of Route 29 and you go to Glens Falls, the team is just wonderful. So brings me to the end. And I've been fielding questions as we go along, but if anybody's been holding on to a question until the end, I'd be happy to answer any questions that folks might have.
Wow, that was fabulous, Dr. Pinto. Thank you so much.
Oh, you're welcome. You're welcome.
And I know NABA is, very grateful for the referrals and working together with your office to help your patients and our participants get the help they need.
Oh, I've described you guys a lot of different ways. To people outside of my field, I've described you as Santa Claus and the Easter Bunny. To my patients, I've described you that way. To my colleagues, I've described you as a safety net. For the folks that I'm doing all I can to keep holding on, but they need more. They need things that I can't personally provide, and that's you. That it's one phone call to NABA, and you're there for them. As a physician, you want to be able to provide everything you can for a patient, but there are limits. Again, like I said, I'm not a low vision specialist. I don't even sell glasses, but I try everything else. And when there are folks that are needing more, you're there for them. So I can't thank you folks enough.
Oh, absolutely. I'm now having a good time picturing the leadership team all in bunny suits. It's true.
You have an interesting imagination.
Yeah, I can't wait to play with that on social media. This has been super informative, but I'm sure there are some questions. And if anyone came in late and may have missed the beginning, the good news is that each of the presentations is being recorded, and hopefully by the beginning of November, they will all be on NABA's website. So if anybody missed anything, you don't have to miss it for long. That's the good news. So, if you are calling in and wish to unmute yourself, please press *6. That is a toggle to mute and unmute yourself, and you're welcome to join us with a question. One thing I learned today on your presentation is I didn't realize that the wet and dry macular degeneration had such different speeds in affecting people's
Really,
vision.
it really is good. I mean, the dry form can progress so slowly that nobody knows they have it until they get their eyes examined and are told, hey, you've got some macular degeneration. Even though, to be a little more technical, the macular degeneration affects the layer of the retina that provides nutritional support for the retina, for the rest of the retina. And what happens is this layer deteriorates. The retina keeps hanging on. It's like somebody who's running a marathon's kind of run out of gas, keeps on running. But eventually, if there's no water station or no candy that gets you some sugar, as a runner, you're not going to keep running. And at some point, your retina is going to say, "Oh, you know what? I'm not working anymore. You're just going to have to deal with a fuzzy picture because I can't develop it for you anymore." And that's the dry form of macular degeneration. What this layer does, this layer that's this nutritious layer that's deteriorating, also does, it's responsible for keeping the retina dry. The retina is like wallpaper. You don't want any fluid behind it. You get some fluid behind your wallpaper, it bubbles up, it peels off, it looks horrible. Well, when your retina starts to bubble up, it abruptly stops functioning. And it could be from leaky fluid, it could be from actual bleeding, and it's because this nutrient layer just is not keeping it dry anymore, and some fluid is broken through. In what may have been marginally poor vision from your dry macular degeneration, almost immediately becomes horrible vision. Now, what used to be blurry is now just black. And that's where the treatment for the wet macular degeneration comes in. You can, as I said, most of the time it involves an injection into the eye, which is not as bad as it sounds. Or it used to involve laser treatments to the eye to seal up where it's leaking. What that does is it dries it back out. It doesn't restore your vision to what it was when you were 20 years old. It gives you the vision that you had before you had the hemorrhage. So yes, there are treatments for macular degeneration. Don't be lackadaisical about getting evaluated for it, because the treatment only restores what was there before the abrupt turn down. It doesn't get you seeing like you did back when you were 20. There's a question that got typed in. Do you recommend taking PreserVision AREDS 2 for AMD? Generally, yes. I hate to qualify all of my answers, but I'm going to qualify this one. The research that went into looking for PreserVision AREDS 2 refers to a vitamin compound that has, among other things, AREDS 2 has lutein, zinc. Plain old AREDS has beta carotene instead of lutein. They're basically antioxidants, something that provides nutritional support to the retina, specifically to the macula, which is the central part of the retina. The research that looked into it showed that it's not a spectacular benefit. You like to think that if you have problems with the nutritional layer of the retina, that providing more nutrition just makes up for that. It only does so to a limited extent. And to be more specific, what was shown to be helpful is that if you have a moderate degree of macular degeneration, not just a mild form and not a severe form, if you have a moderate degree of macular degeneration, this is what your doctor would say, you're mild or moderate. If you have a moderate degree of macular degeneration, you take the vitamins, you have about a 10% lower risk of progression. Now, that's not dramatic. You get 10% off at a department store. You don't get all excited, but you don't turn it down either. You got a 10% coupon. You're going to use it. You're not going to sing a happy song maybe, but every little bit helps. So if you have it to a moderate degree, that's where it's been shown to be helpful. Now, as a physician, I'm allowed to make recommendations that don't necessarily follow the research. And if I'm dealing with somebody who really wants to be as proactive as they can, but they only have a mild degree of macular degeneration, I'll still recommend the AREDS 2 for them. And again, I don't have stock in the vitamin companies. It's not like I'm trying to make a buck on the deal. I don't sell it in my office. and maybe that helps my credibility, but if you're somebody with a mild degree of macular degeneration or a severe degree, people that were not shown the benefit, but they want to be proactive, they want to feel like they're doing something, they may be doing something. It's just that the research didn't show it. It may still help them personally. So I've recommended it for them as well. The cost of the vitamins can be a little prohibitive. So if they have a moderate degree of macular degeneration, I say, you know what, make the sacrifice, perhaps if you can. On the other hand, if they have only a mild degree and it's going to be cost prohibitive, I explain that, you know what, you can just take a general multivitamin and maybe get the same benefit. And this question that just came up is about what I was about to say. Preservision, I'm pretty sure is a brand name of Ocuvite. But there are other vitamins made by other companies that still have the AREDS2 formula. AREDS is an acronym that stands for the Age-Related Eye Disease Study. And there were two of them. So that's why you have AREDS1 and AREDS2. That's a specific formula for a vitamin, a certain amount of beta carotene, a certain amount of lutein, a certain amount of zinc. It's a particular formula. Preservision is one brand. I think it was the first one out. I think it, I forget who developed it. I think Bausch & Lomb has it now, but I'm not here to advertise for them. Preservision, I think, is one brand of AREDS2 vitamin. If you can buy Price Chopper brand AREDS2, it's going to be the same stuff. The pill might be bigger, might be a little harder to swallow, might not be as nice of a color, and the bottle might not be as colorful, but it's the same stuff. So great question. Ocuvite is the general, I think it's Ocuvite Preservision, if I'm not mistaken, but I might be mistaken. But we're talking brand names now, and it's AREDS2 is really what you're looking for, or AREDS1. And just to be a really stickler on this, if you're still smoking cigarettes, which you shouldn't be doing, is probably the single best thing you can do for your eyes to stop smoking or not start. AREDS2 is better for smokers because the beta carotene in AREDS1 apparently raises your risk of lung cancer. So AREDS2 is for you if you're a smoker.
Wow, that's
I'm sorry, getting back to for people with a mild degree or with a family history, I usually do recommend a general multivitamin like Centrum Silver or Price Chopper brand Centrum Silver. Something that does have some lutein in it, that does have some zinc in it, but doesn't have to be the horse tablet of Preservision, and with the cost involved in that. And sunglasses. Sunglasses, always a good idea. Keep your eyes out of the sun. Baseball cap to shade your eyes, or something with a brim, and sunglasses, which I'm not that good about myself, but I'm getting better.
excellent. Actually, that I was doing a presentation in Cobleskill early this week, and the ladies who were at the presentation, we kind of started a short discussion on one. It's just amazing for all the things that can go wrong, how often things go right in the eye. But one of the participants in particularly asked me is age, is everything just is all of this stuff just age related and this is a natural part and going to happen to everybody? Or, is really exercise and eating right for the duration really going to make all the difference in the world?
The only thing that's inevitable with age, other than death and taxes, is cataracts. Everybody starts to develop a cataract. In other words, the lens starts to become cloudy once you hit your late 50s to early 60s. Macular degeneration is not inevitable, although once you reach your 90s, about half of the people will have it. But it is not inevitable. Diabetes certainly is not inevitable. And if you do have diabetes, but you do keep excellent control of your sugar, your blood pressure, and your cholesterol, diabetic retinopathy is not inevitable. And that's something I've just seen, in my 30 plus years in practice. The number of people with bad diabetic retinopathy is really dropped down as we get better and better about controlling sugar, as we become aware of how important it is to also make sure the blood pressure is under control and cholesterol is under control. It's a triple whammy that does a number on the retinas and the kidneys and feet and heart. But as we've learned how important tight control is, I'm seeing much less retinopathy in my practice, which suits me fine. I don't mind that my laser is collecting dust because I don't have to do as nearly as many lasers as I used to. I'm perfectly happy with that because, again, lasers try to preserve what's there, often with some risk with the treatment. I just as soon have prevent the problem than try to treat it afterwards. So yes, healthy living, clean lifestyle, that's going to go a long way. The stuff our moms told us.
Excellent. Thank you. Well, we have about 2 minutes left before our next presenter will be here. So if there is one more question, we do have time. Please don't hold back. In the meantime, I would very much like to thank you so much on behalf of all of NABA for presenting here this morning. We do have just 2 minutes left. Your presentation was lovely, and it so answered a lot of questions I know I've been asked giving low vision presentations, and clarifying a few of the answers for me too. So thank you so much.
Oh, sure.
To take us out, if there's one thing that you want people to remember as they're moving forward to know about eye care, low vision, what would be the one thing that of all of this that they'd have to go back and maybe watch the video to recall? What would be the one takeaway that you would think would be most pertinent?
Could I please have 2 takeaways?
Absolutely.
Okay.
You're the doctor.
The first, okay. Well, the first takeaway is get your eyes examined. Be regular about getting checkups for your eyes, because it's much easier to prevent problems than it is to try to treat them as they become worse. Second thing is support NABA whenever you can.
I wholeheartedly agree with that. And again, thank you so much, Dr. Pinto, for being with us this morning. And I look forward to working with you in the future.
Likewise.
Great. Thank
Thank
you.
you.